Hello and welcome to part 3 of the hemorrhagic shock case of the case file, the emergency medicine book. Last we spoke of the lab values for the hemorrhagic shock case, and now we'll continue in the hemorrhagic shock case in the last part, inshallah, about central monitoring. Central monitoring. Cardiac filling pressures to determine intravascular volume status may lead to inaccurate assessment in the critically ill patient population. The intended purpose of central venous pressure measurement is to determine the cardiac preload. Because the preload is the driving force behind cardiac output as defined by the Starling curve, strictly defined, preload is the end diastolic sacromere length, which cannot be measured clinically. Therefore, the clinician indirectly calculates preload from a measurement that is 4 steps removed from end diastolic sarcomere length. At the bedside, the placement of a pulmonary artery catheter has provided the clinicians the ability to indirectly assess preload by measuring pulmonary capillary occlusion, wedge pressure, that represents the B, left arterial pressure. Left arterial pressure is the indirect measurement of C, left ventricular and end diastolic pressure, which is finally correlated to D, left ventricular end diastolic volume. I'll repeat it without mentioning the steps or letters. So, the ability to indirectly assess preload by measuring pulmonary capillary occlusion pressure that represents the left arterial pressure. Left arterial pressure is the indirect measurement of left ventricular end diastolic pressure, which is finally correlated to left ventricular end diastolic volume. Left ventricular end diastolic volume is our best clinical estimate of preload. After making all these assumptions, it is the pulmonary artery occlusion pressure that is the surrogate preload on which intervention is based. The pulmonary artery catheter, however, is able to provide the clinician with more than pulmonary capillary occlusion pressure. The cardiac output, systemic vascular resistance, oxygen consumption, oxygen delivery, and mixed venous oxygen saturation can all be measured or calculated. Trends or changes in the baseline hemodynamic parameters are probably the most useful information that clinicians can use to determine the adequacy and success of resuscitation. Because the need of a human body in shock exceed those in a normal healthy state, it has been suggested that adequate resuscitation in the critically injured should reach supranormal cardiovascular endpoint. Patients who naturally obtain supranormal hemodynamic parameters may have improved outcomes. However, resuscitation patients with the goal of obtaining supranormal cardiovascular endpoints does not appear to improve survival. So, management of hemorrhagic shock. Resuscitation. The most common and easily available fluid replacement is isotonic crystalloid solution, such as normal saline or lactated Ringer solution. For each liter of these solutions, about 300 milliliters stay in the intravascular space, and the remainder leaking into the interstitial space, leading to the guideline of 3 milliliters crystalloid replacement for each 1 milliliter of blood loss. 3 milliliters crystalloid replacement for each 1 milliliter of blood loss. When the patient persists in shock despite the rapid infusion of 2 to 3 liters of crystalloid solution, or if the patient has had such severe blood loss that cardiovascular collapse is imminent, then a blood transfusion is indicated. When possible, typed and cross-matched blood is optimal. However, in the acute setting, this is often unfeasible. Type-specific unmatched blood is the next best option, followed by O-negative blood. Blood is generally administered as packed erythrocytes or packed red blood cells. Crystalloid, fresh frozen plasma, and or platelets may need to be transfused if massive blood volumes have been given. So blood is generally administered as packed erythrocytes or packed red blood cells. Crystalloids, fresh frozen plasma, and or platelets may need to be transfused if massive blood volumes have been given. Transfusion protocols differ by institution regarding the ratio of fresh frozen plasma to platelets to PRBCs that should be administered. Colloid solutions such as albumin, anhydrous starch, or dextran are not superior to crystalloid replacement in the acute setting and have the potential for large fluid shifts and pulmonary or bowel wall edema. Hypertonic solutions such as 7.5% saline have the advantage of retaining as much as 500 milliliters in the intravascular space and may be useful in trauma situations with no access to blood products, such as in military settings. Lastly, controlling hemorrhage. Achieving hemostasis is paramount in managing the trauma patient with hemorrhagic shock. Wounds amenable to local tamponade with direct pressure dressings or trunquet application should be managed as such. For other injuries that require operative repair, such as intra-abdominal injuries, or for pelvic fractures that require advanced therapies, such as interventional radiology-guided embolization, the appropriate specialists should be contacted immediately. While contacting and arranging for further definitive care, resuscitation of the patient should be initiated. So, in summary, the clinical pearls of this case: hypotension in a trauma patient is hemorrhage until proven otherwise. A trauma patient should be assessed systematically for the source of hemorrhage. Laboratory evaluation is not as sensitive as the combination of history, clinical examination, physical examination findings, and vital sign abnormalities for the diagnosis of hemorrhagic shock. Therapy must be initiated promptly with fluid and or blood product administration. Definitive therapy for control of hemorrhage should be arranged as soon as possible. Thank you very much for watching, and please stay tuned for our next case in the emergency medicine case files. Thank you so much. Tashakkurlar. And please don't forget to like, subscribe, comment, share, ring the bell, and please don't forget to I forgot.
Bye-bye.